everyone. My name is Sonal Kumar. I'm a hepatologist at Weill Cornell Medicine in New York, New York. I'm here at the Allied Digestive Health Annual Conference. It's been such a great time here to hear everyone speak. I spoke about PBC today and updates in PBC diagnosis and management of patients. So the PBC symposium really focused on how we should be assessing our patients for PBC with a focus on considering this disease in all patient populations, but recognizing who are most at risk for getting PBC, and what is the typical demographic that we see. Like, it's a female predominant disease. Middle-aged females are the ones that get it, but we don't want to discount other populations, especially males, because when they get PBC, when they're diagnosed with PBC, it's often in later stages of disease and they have a worsened prognosis. We also spoke a lot about what our goals of treatment should be in patients and how we're really shifting from algorithms of how we should be managing these patients based on previous guidelines that are now, frankly, outdated, but focused on starting first-line treatment and then waiting a year to see how they do on first-line treatment, and then assessing whether they would be candidates for second line, to assessing patients, especially those that are at higher risk, to earlier in their disease course. So we really know who's going to respond to UDCA or first-line treatment very early after starting the medication. A lot of the response happens within the first few months, and definitely by 6 to 9 months, we know who is considered a responder versus a non-responder. And so we should be assessing these patients, especially if they have really high alkaline phosphatase levels, if they have more advanced fibrosis, if they're younger. We really should be assessing these patients by the 6-month time point, and then assessing whether second-line therapy is useful for those patients. Other things that came up are what our goal of treatment should be. So if we're going to be assessing patients at 6 months, or even if you're waiting to the 12-month standpoint, what really should be our goal for treatment? And we talked about how alk phos levels are a very important biomarker for disease progression in PBC. And there have been historically a lot of different cutoffs that people have used for what should be considered a positive response to treatment, or someone who is a non-responder. And now we're really shifting towards normalization of alkaline phosphatase. Because alkaline phosphatase correlates so well with disease activity, if you were to do a liver biopsy on these patients, the degree of elevation in alk phos really correlates with the damage that you're seeing on liver biopsy or histologically. We really should shoot to normalize our alkaline phosphatase levels. And that goes for bilirubin as well. But bilirubin we typically see more elevated in later stages of disease. And actually, early on, our goal for bilirubin should be less than 0.6 times the upper limit of normal. So really shifting our paradigm of care for patients with PBC. Again, assessing them early on, being more aggressive in patients who have more advanced disease. And then our treatment goals really should be normalization of their biomarkers because they correlate so well with disease activity. And then we finished up talking about the new medications that have been approved. It's been such an exciting year for the world of PBC. We haven't had any new second-line therapies since obeticholic acid was approved in 2016. But now in the last year, we've had 2 new PPARs be approved. So we talked about both the Elafibranor trial for Elafibranor and the response trial for Seladelpar, and how both of those medications really showed an improvement in alk phos levels of patients who were inadequate responders to UDCA. And those trials also looked at normalization, which is nice. It's the first time we're really seeing a focus on normalization of alkaline phosphatase. And both of the drugs, Elafibranor showed 15% normalization of alk phos levels in the Elafibranor trial, and Seladelpar showed 25% normalization in the response trial. And so though that's been a really nice shift and a really nice addition of having new second-line therapies for PBC. And then the other thing that I don't want to forget about talking is symptoms. In the past, really haven't focused much on symptoms because they've been really tough for us as providers to address. And sometimes we're not really great about asking our patients about whether they're symptomatic in PBC. But one of the unique parts of PBC is that patients can often be symptomatic, with pruritus and fatigue being the most common symptoms that we see. And I always stress to providers that if you ask about these symptoms, you will find them. But if you don't ask, you'll never know who's symptomatic, because oftentimes patients don't bring it up, and probably because they don't actually associate pruritus and fatigue with PBC. It's not really something that patients may be familiar is part of the disease and is part of that what we see in patients with PBC. But it's very common. Pruritus, 70% of patients, fatigue, at least 50% of patients have it. And so it's really important that we address it. And then the second line therapies now, the new PPARs that were approved, actually looked at effect on symptoms in their clinical trials. And it's really nice to see that they've had an impact on symptoms as well, with Seladelpar actually reaching statistical significance in their assessment of pruritus in patients who had baseline pruritus at the 6-month mark in the response trial. So overall, this has been a great conference. It's been great to hear everything, all the new and exciting things going on, and especially in PBC, where we have a new focus in terms of how we're addressing our patients, managing our patients, and new medications with which to treat them with.